the C3 to C6, and it is a bit high level in the human. Males and females, differences are there. It extends from the C3 to C6. This is the larynx of the infant. The infant larynx differs markedly from its adults, 1/3 of size, and it is short and funnel shaped. And it is higher in the neck. The ventricles are smaller. Mucosa is very loosely attached. The development of the larynx starts in the 3rd and 4th week of intrauterine life. The respiratory primordium appears in the floor of the 4th year. The larynx begins as a slit-like diverticulum on the laryngotracheal groove in the ventral wall of the primitive pharynx. The groove gradually deepens and it adjusts fuse to form a septum. The septum separates the laryngotracheal tube from the pharynx and esophagus posteriorly, that is dorsally. Between 5th and 6th weeks, 3 swellings appear at the laryngeal edictus. The anterior swelling, that is from hypopharyngeal eminence from the 4th arch, forms the epiglottis. 2 lateral arytenoid swellings, they derived from the 6th branchial arch, forms into the arytenoids there. By the 10th week, recanalization occurs to form a pair of laryngeal ventricles. The laryngeal ventricle are bounded by mesenchyma tissue that contains and progress into false and true vocal cords or ligaments. The thyroid cartilage, as you know already, it develops from the 4th arch mesenchyma, and the arytenoids, corniculate and cricoid trichoid cartilage, tracheal cartilage develop from the 6th branchial arch. The intrinsic muscles, which acts the movement of the larynx, develops from the mesoderm of the 4th and 6th arches. The infant larynx is actually 1/3 of the adult size, proportionally larger. Mucosa is lax. It is the narrowest in subglottic area, that is 3.5 mm. Sexual difference is apparent in 3rd year. They can differentiate male and female sex. Males are larger and angle between thyroid lamina are more pronounced than in the females. Epiglottis at C2 and C3 level. The difference between adult and infant, you can remember as a 7S. Size is smaller in infant, shape is funnel shaped in infant, cylindrical in adults. It is soft in infants, superiorly placed in infants, straighter and less oblique than in adults. Sensitivity is greater in infants because that is the reason why it is more prone for spasms. Subglottis is very narrow. The dimensions of the larynx differs in males and females regarding the length. 44 mm males, females 36 mm. Transverse diameter, that is side to side, 43 millimeters, 41 millimeter in females. Sagittal diameter, 36 millimeters in the males, that is anteroposterior. Females, 26 millimeters. The internal cavity of the larynx is divided into supraglottic, glottic, and subglottic. Supraglottics is superiorly limited by epiglottis and aryepiglottic folds, and inferiorly the ventricular bands, that is what we call false cords. The glottis superiorly is the ventricular bands, and inferiorly at the level of the 2 cords, that is vocal ligaments, are about 5 to 10 mm below the vocal cord. The subglottis, this becomes trachea at the lower end of the cricoid area. The laryngeal framework consists of cartilages, joints, ligaments, membranes, muscles, mucous membrane, and a hyoid bone. The hyoid bone is a U-shaped bone. It can be palpated, thin and curved bone. Only bone does not articulate with any joint. The greater horn gives attachment to the lateral thyroid ligament, the lesser horns to the stylohyoid ligament. This is the hyoid bone. There are three paired and three unpaired cartilages are there. Three paired cartilages are arytenoid, corniculate, and cuneiform cartilages. Unpaired are the thyroid, cricoid, and epiglottis. Thyroid cartilage, the two lamina are fused in the midline, giving rise to laryngeal prominence in the front of the neck. In the males, we call it as an Adam's apple, as you know. The angle of fusion in the males is the 90 degrees, and female it is 120 degrees. The posterior part is prolonged above and below to form the superior and inferior cornea, like this. The cricoid cartilage is shaped like a signet ring. The signet shape posteriorly and the arch is anteriorly. It is situated at the level of C6. The cricoid lamina has two superior facets articulate with the arytenoid cartilage, and it has two lower and lateral facets articulate with the inferior horns of the thyroid cartilage to form the cricothyroid joint. The lower border is joined to the first tracheal ring through cricotracheal ligament or a membrane. Arising from the arch of cricoid cartilage anterior and externally are the cricothyroid muscle. You are seeing here the cricothyroid. The lamina has a midline ridge for the tendinous attachment of the longitudinal fibers of the esophagus. Esophagus that attaches to the posterior surface of the cricoid cartilage. Lateral to this ridge are the sites of origin for the bilateral posterior cricoarytenoid muscles here. The surgical consideration, injury to the cricoid cartilage from any intubation or trauma leads to subglottic stenosis. To repair this long-standing subglottic stenosis, the expansion of the cricoid ring is attained by autologous cartilage grafts by splitting it. The tracheostomy, what we perform, it should be done below the first tracheal ring to avoid subglottic stenosis in always. During an emergency cricothyroidotomy, the tracheostomy tube is inserted through the median cricothyroid ligament or a cricothyroid membrane that is the quickest, easiest access to the area. Next, arytenoid cartilages. You are having it is a pyramidal in shape. It has three surfaces, a base and an apex. Each triangle shaped, the base articulates with the cricoid cartilage by way of diarthrodal joint. The base has two processes. That is, anterior directed one is the vocal process, where the vocal ligament is attached. And another one is the lateral process, where the muscular process, lateral and posterior cricothyroid. This is the muscular process where the lateral and posterior cricothyroid muscles are attached here. Arytenoid has three surfaces. Posterior surface, which is transverse and oblique. Arytenoid muscles are attached here. The medial surface covered with mucosa. Anterolateral surface is insertion of the thyroarytenoid muscle, part of the vocalis muscle, and the vestibular ligament. The apex of the arytenoid cartilage supports the corniculate cartilage here. You can see here the corniculate cartilage. Surgical consideration, cricoarytenoid fixation may occur from arthritis or perichondritis due to intubation injury. It limits the vocal cord mobility many times. The cricoarytenoid are subluxation during blind intubation with a laryngeal lighted stylet that also can cause a subluxation. In these conditions where there is a voice change, it is corrected by the arytenoidectomy through an external or endoscopic approach to correct this fixation or paralysis and voice change. We are having corniculate cartilages, which are present over the apex of the arytenoid cartilage. They are paired conical elastic fibrocartilages, articulate with epiphysis of arytenoid, situated in the posterior part of the aryepiglottic fold. The cuneiform cartilages, they are also paired. They are small elongated flaps, fibroelastic cartilage, they are fibroelastic. In margin of aryepiglottic fold, they are present. The cricothyroid joint is in between the inferior cornea of the thyroid cartilage and the sides of the cricoid cartilage. This is the cricothyroid joint. It is a synovial joint, affect the movements to lengthen the vocal cords, which in reverse increase the vocal fold tension. Cricoarytenoid joint is between the facets on the lateral part of the upper border of the lamina of cricoid cartilage and base of the arytenoids. This is also a synovial joint, and it has a capsular ligament. You are seeing here. This is the cricoid arytenoid joint. Arytenocornicular joint also, they are synovial or sometimes cartilaginous. Between arytenoid and corniculate cartilages, all these joints is innervated by recurrent laryngeal nerve. Coming to the laryngeal membranes, the first membrane is the thyroid membrane. It provides an extensive connection between the thyroid cartilage and the hyoid bone bilaterally. See, this is the what you call thyroid membrane. Extending from the upper border and the greater horns of the hyoid bone, it comes up to the upper border of the thyroid cartilage and also the superior cartilage. It is thickened anteriorly to form the median thyroid ligament, and this is thyroid membrane, and it is thickened posteriorly to call it as a lateral thyroid membrane, this part. And it is having a small cartilage, as you can see, this is called the tritecial cartilage. The superior laryngeal neurovascular bundle, that is very important when we do the surgical steps in the pharynx operation or laryngectomy or thyroidectomy. This can possibly be injured sometimes in cases of surgery. That's why this is both superior laryngeal artery and nerve. They pass in the thyroid membrane. The tritecial cartilage, which I had told you, they are present here in the lateral thyroid ligament. The cricotracheal membrane connects the most superior tracheal ring. What you are seeing here, this is the tracheal ring. It is connected to the lower margin of the inferior border of the cricoid cartilage by cricotracheal membrane. The intrinsic membranes connect the laryngeal cartilages with each other to regulate the movement. We are having two intrinsic membranes. One is called the conus elasticus. Second one is called the quadrangular membrane. Conus elasticus connects the cricoid cartilage with the thyroid cartilage. This part. Cricoid cartilage, thyroid cartilage. It has two parts. The median cricothyroid ligament, what you are seeing here. Another one is the lateral cricothyroid membrane. Median cricothyroid membrane connects the anterior part of the arch of the cricoid cartilage with the inferior border of the thyroid membrane. The lateral cricothyroid membrane originates from the superior surface of the cricoid arch and it rises superiorly and medially to insert posteriorly on the vocal process and anterior to the interior median part of the thyroid cartilage. This free border is called the vocal ligament or a true vocal cord area. Quadrangular membrane extends from the sides of the epiglottis anteriorly to the anterolateral surface of the arytenoid cartilage and posteriorly to the corniculate cartilage. Its covering of mucous membrane forms the aryepiglottic fold here and superiorly and vestibular ligament inferiorly. It forms the medial wall of the pyriform fossa. Cuneiform cartilages are embedded within the aryepiglottic folds. The free inferior borders of the quadrangular membranes form the ventricular ligaments and also known as the false vocal cord. See this one. Above one is the true vocal cord, the false vocal cord. This is the true vocal cord. The true vocal cord is formed by the conus elastic. This is the quadrangular. The ligaments, epiglottic ligaments, aryepiglottic fold, vestibular ligament, vocal ligaments. Epiglottic ligaments and its folds, you are having one from epiglottis to the hyoid is hyoepiglottic ligament. Another one epiglottis to the thyroid, thyroepiglottic ligament. From epiglottis to the tongue, we are having two folds, what you call median glossoepiglottic fold and a lateral glossoepiglottic fold. In between the deep valley-like area is called the vallicula. Aryepiglottic folds, one on each side, contain aryepiglottic muscle inside, associated with the superior border of the quadrangular membrane. Already we discussed. Both aryepiglottic folds constrict the entrance to the larynx and protect the respiratory tract during deglutition, that is during swallowing it protects. The vestibular glands, that is false vocal cords, formed by the inferior edges of the quadrangular membrane, attaches in front to the thyroid cartilage just below the attachment of the epiglottis, connected behind to the anterolateral surface of arytenoid cartilage. The vestibular ligaments are located just above the vocal cords, separated from them by a bilateral ellipsoid spaces called the laryngeal ventricles. Overlap the true vocal cords just prior to the cough and sneeze. Reinforce true vocal cords against the internal expiratory pressures. See here you are seeing both true vocal cord and false vocal cord. Vocal ligaments are vocal cords, that is the true vocal cord. It is a thickened ligamentous upper edges of the elastic tissue of the conus elasticus are the vocal ligaments. They extend from the median extremities of the lamina of the thyroid cartilage and the midline anteriorly to form the anterior commissure. From there, it goes posteriorly, attaches to the vocal process of the arytenoid cartilage, and one on each side. Histologically, this is having 5 layers. The layer 1 is the squamous epithelium. It doesn't have any mucous gland. Layer 2 is having a superficial layer of the lamina propria. It is composed of loose fibers and matrix, minimal elastic and collagenous fibers. A third layer called intermediate layer of lamina propria, high concentration of the elastic and collagenous fibers. Deep layer of the lamina propria contains a dense collection of the elastic and collagenous fibers. This layer along with the intermediate layer constitute the vocal ligament actually. This is layer 5 is formed by the vocalis muscle The fibers of this thick muscle run parallel to the direction of the vocal cord. This is the structure what you are seeing. The vocal cord. Rima glottidis, that is the main opening of the laryngeal inlet. It is divided into two parts. The posterior two-thirds between the vocal process of the arytenoids is called the respiratory glottis or interarytenoid space. That is between the two vocal process. The anterior 3/5 membranous part are a glottis vocalis. The muscles of the larynx are divided into extrinsic muscles and intrinsic muscles. Extrinsic moves the entire larynx, intrinsic moves the only vocal cords. They are elevators of the larynx divided into suprahyoid and longitudinal muscles of the pharynx. Suprahyoid muscle is a digastric, stylohyoid, mylohyoid, and genohyoid. These are the suprahyoid muscles. And longitudinal muscles of the pharynx are stylopharyngeus, salpingopharyngeus, and palatopharyngeus. The depressors of the larynx are infrahyoid muscle. They are the grouped as sternohyoid, sternothyroid, and homothyroid. These are depressors. Coming to the intrinsic muscles. Intrinsic muscles are named like cricothyroid, posterior cricothyroid, cricoarytenoid, and lateral cricoarytenoid. Arytenoid with its oblique and transverse fibers, thyroarytenoid and its thyroepiglottic and its components. The muscles which control the laryngeal inlet is oblique arytenoid and aryepiglottic folds. See, this oblique arytenoid and aryepiglottic fold, they control the opening of the laryngeal inlet during deglutition and swallowing. The movements of the vocal cords are divided into adduction and abduction. This is adduction and this is abduction. Glottic space is open in between. The abductors of the vocal cords are lateral cricothyroid and transverse arytenoid. See, this is the lateral cricothyroid and the transverse arytenoid. They make the vocal cords to come together, what you call adductors of the vocal cords. They make vocal cords come together. This is how they act. This is lateral. When they pull it, the vocal process comes medially and the adduction is seen. And another thing is transverse arytenoid. They bring both arytenoids together. Abductor of the vocal cords is the main one is the posterior cricoarytenoid. See this, when this posterior cricoarytenoid contracts, the vocal process will go away and it creates what you call abduction here. This is the posterior cricoarytenoid is the muscle which is primary is an abductor. The vocal cords, which maybe the length and tension will be changed by different muscles. The increasing of the length and tension is mainly done by the cricothyroid muscle. It increases the distance between the angle of the thyroid cartilage and the vocal process of the arytenoid, which results the length and the tension increase in the vocal cords, cricoarytenoid. This is another cricothyroarytenoid, that is what you call vocalis muscle, pulls the arytenoid cartilage forward towards the thyroid cartilage and thus shortens and relaxes the vocal cords. The tension is reduced and the length is also reduced by thyroarytenoid. This is what called string muscle of the larynx. The sphincter function of the larynx, there are two sphincters are there. At the inlet used only during swallowing, that is aryepiglottic fold closure and epiglottis for posterior bending. At the remaglottis, it is used during coughing and sneezing, where you find total closure here. This is closure. This is a normal phonation, the vocal cords come together, and this is what whisper. Actually, to whisper, the vocal cord strains more compared to the normal speech. Mucous membranes of the larynx, this is actually lined by pseudo-stratified ciliated columnar epithelium. That is same as the respiratory type. Non-keratinized stratified squamous epithelium in some parts present. That is what you call upper half of the posterior surface of the epiglottis, upper part of the aryepiglottic folds, and posterior glottis and vocal folds. This is the area sometimes we get squamous epithelium, that is the carcinoma from the squamous type. They are closely attached over the posterior surface of the epiglottis, corniculate, and cuneiform cartilages, and over the vocal ligament, true vocal cords. But other areas it is loosely attached. That is the reason why it is more prone for edema. Angioneurotic edema occurs in the larynx, which is a dangerous condition. That's why, because of this mucous membrane loosely attached and prone for edema. The spaces in the larynx, we are having a pre-epiglottic space. It is a wedge-shaped and it is called a space of Boyer. The boundary is anteriorly thyroid ligament and hyoid bone, posteriorly the epiglottis, superiorly by the hyoepiglottic ligament. That's why it is a wedge-shaped one. There is another space what we call paraglottic space. It is bounded laterally by the thyroid cartilage, medially by the conus elasticus and quadrangular membrane, posteriorly by the piriform fossa mucosa. A third space which you know present in the vocal cords is the Rinky space. Next, coming to the nerve supply. This is very important. As you know, the left recurrent laryngeal nerve and right recurrent laryngeal nerve, both are the branches of the vagus and also superior laryngeal nerve. They take part. The left goes a little more into the depth of the thorax, but the right is coming from only superficially. Coming to the superior laryngeal nerve is one of the branch of the vagus. The internal branch, that is what you call sensory branch, supplies the areas above the glottis. Above the glottis, it is supplied by the sensory part by superior laryngeal nerve. The external branch supplies what you call the external branch is called the motor or sensory. Motor is cricothyroid only, and sensory anterior infraglottic larynx at the level of the cricothyroid membrane. You have to remember like that: superior laryngeal sensory part above the glottis, motor part only cricothyroid, a little sensory is present. Inferior recurrent laryngeal nerve, motor, all intrinsic laryngeal muscles of the same side except cricothyroid, and interarytenoid muscle on the both sides is innervated by both the recurrent laryngeal nerves. See, in motor, all intrinsic laryngeal muscles of the same side except cricothyroid innervated by the inferior or recurrent laryngeal nerve. But interarytenoid muscle will get an innervation from both recurrent laryngeal nerves on the opposite side, both sides. Sensory areas below the glottis is supplied by the only recurrent laryngeal nerve. This is what we are seeing left and right recurrent here. The blood supply of the larynx, primarily arterial supply, above the larynx, you will see the external carotid artery. The upper part of the larynx is supplied by external carotid artery, superior thyroid artery, and superior laryngeal artery. The lower part of the larynx below the glottis is subclavian artery, thyrocervical artery, inferior thyroid artery, and inferior laryngeal artery. You can see here, all are the branches. They are entering here. Inferior laryngeal. Also, this is the superior laryngeal artery. The venous supply. The upper part of the larynx, above the vocal cords, by the superior laryngeal vein. And inferior, next is the superior thyroid vein, internal jugular vein. These are the three veins supply the upper part of the larynx, that is above the glottis. Below the glottis is that is lower larynx by inferior laryngeal vein, inferior thyroid vein, and subclavian vein. You are seeing here superior thyroid vein, and here is the inferior thyroid vein. The lymphatic drainage. Above the vocal cords, the superior lymphatics drain to the upper deep cervical nodes, located at the level of the carotid bifurcation. Some drainage passes to the prelaryngeal nodes, that is what you call Delphian node. You see, it is the anterior surface of the larynx, there is one node called the Delphian node. Infraglottic area, they drain to the pretracheal lymph nodes of the proximal trachea anteriorly, paratracheal nodes laterally, and then to the deep cervical and superior mediastinal nodes, it can drain. This is how the lymphatic drainage is taken. This is important when you deal with a carcinoma of the larynx. Which level of the lymph nodes are involved, and when you are doing a partial laryngectomy or supraglottic or subglottic laryngectomies, then which nodes has to be separated, that is important, comes with the lymphatic drainage. The glottic area, vocal folds, is relatively devoid of lymphatics. That is the reason why the vocal cords carcinomas very slowly progressive. They are better for the treatment if you detect early, because the moment the voice changes, the patient comes to us and we can start the treatment. That's why the delay will not occur in the vocal cords unless the patient is very neglecting patient. The space deep to the thin mucosa of the true vocal cords, which is called the Rinky space, has no direct lymphatic drainage. That is another thing which is having advantage. It doesn't allow directly to any lymph nodes to involve in the early stage. The spread of carcinoma is likewise unfortunately retarded until an invasive process involves tissue peripheral to the true vocal cords. Unless other areas involved, the growth will not go and will not affect the prognosis point of view. Delphian node, already I told you, it is a midline prelaryngeal lymph node adjacent to the thyroid gland, and enlargement of which is an indicative of metastasis from a thyroid and laryngeal carcinoma. This is the view of the vocal cords, what you are seeing. This is the abduction and this is the adduction. when talking or singing. This is during respiration. Position of the vocal cord. The position of the vocal cord, median, that is in the midline, during phonation and also recurrent laryngeal nerve palsy. The vocal cord which is paralyzed will be seen in the midline sometimes. That is called median position. But during phonation also, it is in the midline only. That is paramedian 1.5 millimeters away from the midline is called the paramedian. When you whisper strongly, it goes into the paramedian. And sometimes in where there is a recovery of the recurrent laryngeal nerve palsy, it may go into the slowly into the paramedian position. If you see for a lately or a few days back afterwards, it may go into the paramedian position. Intermediate is called the cadaveric position. This is a neutral position of the cricoarytenoid joint. Abduction and adduction takes place from this position only, 3.5 millimeters away posteriorly. This occurs when there is a paralysis of both recurrent and superior laryngeal nerve are there. This is what you see in the cadaver position. This is a neutral position, and both abduction and adduction take from this point of view only, from this point only. This is seen when there is both recurrent laryngeal nerve and superior laryngeal nerves are paralyzed. Gentle abduction, which will be about 7 millimeters during quiet respiration occurs. When you ask the patient to examine the larynx, quiet respiration normally we ask first. Normally it goes up to 7 millimeters in the adult patient. This is occurs in the cases of paralysis of the adductors. There is one condition called bilateral paralysis. Sometimes if the adductor muscles are paralyzed, the vocal cords go away from each other. This is another one is called the full abduction, where it goes 9.5 millimeters away in case of deep inspiration. When you wanted to see the vocal cords still more detail, then we ask the patient to go for a deep inspiration. You can see sometimes during deep inspiration, the internal parts of the subglottic area, any masses or any pedunculated masses or hemangiomas like that, or you can see the malignant growths coming from the inferior surface of the vocal cord also. And you can see 2 or 3 or 4 tracheal rings also in these conditions of full abduction. To remember easily, the arterial supply above the vocal cords is superior laryngeal artery. Below the vocal cord is the inferior laryngeal. Venous drainage primarily superior thyroid vein above and inferior thyroid vein below. The lymphatic drainage, that is what you call above the vocal cord, they will go into the upper deep cervical lymph nodes. Below the vocal cord, they will go into the lower deep cervical lymph nodes. The nerve supply above the vocal cord sensory is the internal laryngeal nerve. That is what you call superior laryngeal nerve branch. And below the vocal cord is by the recurrent laryngeal nerve. Thank you.